So this week we're going to talk about borderline personality disorder. All is caprice. They love without measure those whom they will soon hate without reason. Thomas Sydenham, 17th century English physician on hysterics, the equivalent of today's borderline personality. First off, we're going to go over some myths of BPD, otherwise known as stigma. Number one, people with BPD are manipulative and attention-seeking. Number two, people with BPD are violent individuals at high risk of harming others. 3, BPD is a life sentence. 4, BPD is untreatable. 5, BPD is caused by bad parents. 6, people with BPD are crazy and irrational. Number 7, BPD is only found in women. Now we're going to go through a lot of these and let you know that they aren't true. So the criterion for BPD: 1, frantic efforts to avoid real or imagined abandonment. 2, a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. 3, identity disturbance, markedly and persistently unstable self-image or sense of self. 4, impulsivity in at least 2 areas that are potentially self-damaging, such as spending, sex, substance abuse, reckless driving, or binge eating. 5, recurrent suicidal behavior, gestures or threats, or self-mutilating behavior. 6, affective instability due to marked reactivity of mood, intense episodic dysphoria, irritability, or anxiety, usually lasting a few hours and only rarely more than a few days. 7, chronic feelings of emptiness. 8, inappropriate, intense anger or difficulty controlling anger. 9, transient stress-related paranoid ideation or severe dissociative symptoms. Now, in order for diagnosis, people must meet 5 or more criterion. Differential diagnosis often occurs with depressive or bipolar disorder. Be sure to differentiate between other personality disorders such as histrionic, paranoid, antisocial, or schizotypal, which show many of the same characteristics. However, if applicable, more than one personality disorder can be diagnosed. Exclude personality changes from medical conditions or substance use disorder. Also, exclude from developmentally appropriate identity problems. A moody teenager does not necessarily necessitate a BPD diagnosis. Some clinicians would rather diagnose bipolar disorder in order to avoid the large amount of stigma associated with BPD, but this can negatively affect the course of effective treatment. So, where does BPD come from? Attachment disorder. Disorganized attachment style, often seen among maltreated children, can lead to features of BPD. Traumatic experiences such as parental loss and childhood maltreatment increase risk of developing BPD. And about 50% of people with BPD have some kind of childhood sexual abuse. Because of this link to trauma, some people believe BPD is a complicated PTSD, but not everyone with BPD has a history of trauma. It's also very genetic. It's 5 times more common among first-degree biological relatives of those with the disorder than in the general population. Also, the largest study found that if you have BPD, the chances your identical twin has BPD is 35%, but the chances your fraternal twin has BPD are only around 7. Some BPD criterion are more genetically inheritable than others, such as suicidal behavior, impulsivity, and feelings of emptiness. This is a chart which shows the genetic influence of many of the criterion. So how genetically influenced are these? Some are more so than others, as we said before. The course of the disorder. Instability through young adult years with episodes of serious impulsive and affective discontrol. Risk of suicide is greatest in young adult years. Tendency toward intense emotions is lifelong, but individuals who receive treatment show signs of improvement within the first year. During their 30s and 40s, individuals often obtain more stability in relationships and vocational functioning. After 10 years, approximately half of individuals no longer qualify for a BPD diagnosis. So, the idea is that adverse life events can lead to cyclical course of symptomology with borderline personality disorder. Childhood abuse can lead to borderline personality disorder. Borderline personality disorder has many characteristics which make people more vulnerable to other types of trauma or assaults. They don't think a lot before their actions, they're very impulsive, and a lot of times this can lead to PTSD, which in turn only affects more so the symptomology of borderline personality disorder. How various disciplines see borderline personality disorder. So as a psychoanalyst, people see it splitting. So they have black and white thinking, and they leave situations they either love or hate, kind of like that quote in the beginning of the presentation. Dialectical behavior therapy sees it more as emotional dysregulation. Psychopharmacologist is a serotonin and dopamine imbalance. Sociologists believe it has to do with identity. And cognitive therapists see it as a faulty schema. So they're identifying things in a different manner than others. Treatment. So group therapy, because a lot of people with borderline personality is focused on relational aspects. It is often an important part of therapy to experience a group therapeutic process where clients can work on interpersonal skills and gain feedback in real time. Psychodynamic theory is less structured than CBT or DBT, with less emphasis on coping skills and homework and more emphasis on identifying coping and interpersonal patterns, especially in childhood. Medication. Medication can help treat some problems of BPD. Medications given include mood stabilizers, antipsychotics, or antidepressants. All have had some effect on emotional instability, anger, and other psychiatric symptoms in BPD. Of course, medication isn't just a magic bullet. There has to be other treatment going on as well for the best possible outcome. The main treatments right now are CBT, which is cognitive behavioral therapy, and it aims to help people become aware of when they make negative interpretations and of behavioral patterns which reinforce the distorted thinking. And DBT, which was made specifically for suicidal women, and is a specific type of CBT created by Marsha Linehan, specifically for treating those women, and really works well with BPD. And it's focused on a biosocial perspective with an emphasis on skill building and homework. The main goals of DBT include helping clients to become more motivated to work toward a life worth living, help clients to learn important skills and needed to reach their goals, create a treatment environment that promotes progress and improvement and helps the client structure his or her environment in a way that promotes progress, helps therapists stay motivated and skillful in helping their clients, and 5, help clients transfer what they can learn in therapy to their real lives outside of treatment. The main skills of DBT are mindfulness, interpersonal effectiveness, emotional regulation, and distress tolerance. Research on DBT demonstrates that the treatment works. For example, a study in the July 2006 Archive of General Psychiatry showed that suicidal borderline patients randomly assigned to DBT were half as likely to make suicide attempts as those receiving expert treatment as usual, according to blind raters. Things that can interfere with treatment: substance use disorders, PTSD, mood and anxiety, other personality disorders, stigma, and attitudes of clinicians. So let's look at this cycle. Presented at emergency department, and they have self-harmed and in distress. So immediately the BPD label is thrown at the individual with little thought or care by an emergency physician. The BPD individual is disrespected and denied proper treatment because of the stigma of the attention-seeking ideas. This invalidates their pain and reinforces their feelings of worthlessness. They leave feeling worse than they arrived and become more unwell. So this is where we really need to work on validation of their issues, as well as being respectful of them as human beings and not giving into that stigma. Cultural implications. Patterns of behavior have been seen in multiple settings around the world. It is mainly a disorder first seen in adolescence and therefore can be tricky to differentiate between occasional normal adolescent behavior episodes. It is also a predominantly female disorder, approximately 75% according to the DSM-5, although according to our textbook, there is a more even gender ratio. So there are many differences of gender in BPD. So men with borderline personality disorder are more likely to demonstrate an explosive temperament and higher levels of novelty seeking than women with borderline personality disorder. As for Axis 1 comorbidity, men with borderline personality disorder are more likely to evidence substance use disorders, whereas women with borderline personality disorder are more likely to evidence eating, mood, anxiety, and post-traumatic stress disorder. With regards to Axis 2 comorbidity, men with borderline personality disorder are more likely than women to evidence antisocial personality disorder. This can, in turn, affect how much people seek treatment. Therefore, might be why we see it more in females than in men, or why we diagnose it more in females than men. Ethical considerations. When working with people with BPD, you have to keep in mind that you are working with chronically suicidal people who self-harm. Around 75% of people with BPD say they have made a suicide attempt. Between 5 and 10% of people with BPD actually end up killing themselves. And around 69 to 80% of people with BPD say they have deliberately harmed themselves. When we look at the ACA Code of Ethics, the number one and first principle is primary responsibility. The primary responsibility of counselors is to respect the dignity and promote the welfare of clients. So what do we do with a chronically suicidal person? We can't just leave them in a hospital continuously. So here I've looked at how DBT kind of works with this and the ethical considerations of working with chronically suicidal individuals. So Marshall Linehan and DBT strategy is to thoroughly assess suicide risk. We cannot effectively intervene to reduce suicide risk unless we know that suicide risk is present. Therefore, it's critical that mental health professionals routinely conduct suicide risk assessments, ideally using an evidence-based approach such as the Linehan Risk Assessment and Management Protocol. Also, hospitalization. DBT therapists do not typically recommend or rely on psychiatric hospitalizations, but they do remain available to clients between sessions, which is different from other therapy perspectives. So individuals at high risk for suicide often require in-the-moment coaching to navigate difficult situations without resorting to suicide. In DBT, this is done by making therapists available to clients for phone coaching between sessions. Coaching calls are typically brief and focused on helping clients identify skills to effectively manage current and ongoing difficult situations. So we don't want to bring up a dependency on the therapist, but it is more of a reminder of the skills they already know themselves. Resources. Treatment and Research Advancements, National Association for Personality Disorders, the National Education Alliance for BPD, the Borderline Sanctuary, BPD Central, and Behavioral Tech LLC, which is also by Marshall Linehan, and I definitely recommend checking out. And these are the citations. So I hope you learned a lot today, and thank you for watching my presentation.